Welcome to the session on the ASMBS IFSO-ASMBS guidelines on indications of metabolic bariatric surgery. My name is Scott Shikora. I'm the outgoing IFSO president, and I'm chairing this session together with Teresa Lamaster. She was ASMBS president at the time the guidelines were created, and Maurizio De Luca, who is, let's say, the master behind the new paper that will be published in a few days. And this is a very important session for IFSO and ASMBS, and we will present you what changed, how it's implemented all over the world, and also the evidence behind the guidelines. So I think this is very important. We'll have a discussion at the end of that session. I hope we will have some time for that. And we start immediately on, and the first speaker will be Teresa. As I mentioned already, she's really well known all over the world. She has been the president of ASMBS when we had this common project, and her talk will be the new guidelines, what has changed.
Well, welcome. I'm glad to see you're all here, hopefully all awake. I know it's a lot of fun in the evening, so I'm glad to see you here today to have more great discussion. So I was president when the indications came out. This was actually a brainchild of Dr. Qatari, who was president before me, and I got to carry this project over the finish line. This was a collaborative project between ASMBS and IFSO. I'm going to go through my disclosures. These are my disclosures. They don't impact this talk today. This is just my disclosure about my case practice, my practice. So hopefully all of you are aware that this paper was published in 2022. It was co-published in SWORD and Obesity Surgery, and was a very impactful and important paper of the time. And so I'm introducing kind of phase one, and then phase two will come with Maurizio. Just to remind you, why did we do this in the first place? Why were new indications and guidelines needed? Well, there are many benefits of the guidelines. They definitely improve health outcomes and consistency of care, but they also impact policy, which is very important. And certainly in the US, many insurance carriers were still using 30-year-old guidelines. In spite of additional guidelines coming out between that time period and now, they were never widely adopted. And so this really was an opportunity. No other specialty would use 30-year-old guidelines in their indications for procedures. So this was an opportunity as a collaborative, unified voice to come forward and say, this is the time for a new indications. So this process began with an extensive review of the literature. 24 leaders of metabolic and bariatric surgery from ASMBS and IFSO came together from 9 countries to create the guidelines, evaluating the literature and bringing us up to up-to-date evidence-based guidelines. So this project, again, was undertaken to bring it up to date on current evidence and safety. And there have been a lot of advances, certainly in the last 30 years. The NIH put out the guidelines 30 years ago. They are no longer in the business of putting out guidelines, so it was necessary to take a different approach. This began with a literature review, and then the focus really was on procedure types, indications, and then also age limits. And we did identify the most common procedures performed with the laparoscopic sleeve gastrectomy and the roux-en-y gastric bypass, but other procedures that were important included the biliopancreatic diversion with duodenal switch, OAGB. Historical procedures included the vertical banded gastroplasty and the laparoscopic adjustable gastric band that was still present but declining in numbers. And so part of this indications was to look at expanding what the original indications were. And this is primarily related to the substantial improvement and resolution of many significant obesity-related comorbidities with safety outcomes. So prospective large retrospective studies supported the use of metabolic bariatric surgery in class 1 obesity with a BMI of 30 to 35, with comorbidities, but also in class 2 obesity with a BMI greater than 35 without comorbidities. So this was one of the major changes. Other changes were to identify that in people of different ethnic backgrounds, the BMI variables actually are indicative of different levels of disease. So specifically in Asian descent, the development of type 2 diabetes and cardiovascular disease happens at a lower BMI threshold rather than the non-Asian population. And that has to do with their degree of adiposity. So therefore, the BMI thresholds were adjusted to reflect that risk down. It's going a little faster than I was going to do. But so we also looked at expanding the age limits, including greater than 70 years old, who had only slightly higher complication rates related to younger patients. And there was a significant benefit in weight loss and health-related outcomes. The most important factors were actually fragility, cognitive function, and end organ function. There are also more children and adolescents who carry the disease of obesity, and metabolic bariatric surgery is safe and effective in this population with greater benefits than non-surgery. So this was indicated for pediatrics with a BMI greater than 120% of the 95th percentile with comorbidities, or greater than 140th% of the 95th percentile without comorbidities, which would be class 3 obesity. So there are also special populations that can benefit significantly from metabolic bariatric surgery, acting as a bridge to become a candidate for other procedures that have limitations for patient selection related to BMI or health-related comorbidities. So this would include a bridge to joint replacement, abdominal wall hernia repair, and organ transplantation. So metabolic bariatric surgery has also been demonstrated to be safe and effective in other high-risk populations, and this would include high BMI patients with BMI greater than 60, those with liver cirrhosis, and those with heart failure, even to the point of requiring an LVAD. So the evidence supports expanded indications of metabolic bariatric surgery across age ranges and risk profiles due to the outstanding efficacy, durability, and safety to treat this life-threatening disease. So another part of the indications that was expanded that wasn't included in our original visual abstract, but I think is very important, was the focus on a consultation with a multidisciplinary team that can help manage the patient's modifiable risk factors with a goal of reducing the risk of perioperative complications and improving outcomes. Also, there was an emphasis of understanding that obesity is a chronic progressive disease that requires long-term management after the primary procedure. And this could include additional surgery or adjuvant therapy to achieve a desired treatment effect. So just in summary, to understand that bridging the gap between 30 years ago and today, our focus areas were on BMI thresholds, which are actually lower due to the safety and efficacy of metabolic bariatric surgery. Age ranges have been expanded. Metabolic bariatric surgery can be a bridge to other surgical therapies. It can be used very safely in high-risk patient populations with appropriate optimization. The pre-op evaluation and preparation as well as post-op care is important with a multidisciplinary team and a focus on long-term outcomes, not just what happens with the procedure. So we're going to have some great discussions today. Next, I would like to introduce Maurizio. Let's see if we can get his slides up here. There we go. Yeah. So he has been the brainchild of the next document that actually supports the levels of evidence for the guidelines that we presented, because that's the first area of pushback is, well, that's great, you have these new indications. What is the level of evidence behind that? So Maurizio, I would love to have you come on up.
Thank you, Teresa. And first of all, okay, we can go ahead with our. Oh, excuse me. They're looking for my slides. Or maybe we can go ahead with the implementation. Yes, we can do it. Okay, please, Gerard.
Go back and ask. Hi, it's already. Here it is. Okay.
As you want, President.
Thank you.
Okay. So can I have my first slide, please? I'm trying to. No, he's going ahead. I think the second one. Okay. Okay. Okay, thank you. And first of all, I have no potential conflict of interest to report for this presentation. Teresa was very clear to explain how SBS and IFSO board started, considering the previous guidelines, which was a consensus conference of 1991, which considered, for example, age only between 18 and 60 years old. This is the first thing that I want to point out. And BMI more than 35 with the comorbidities. But, as Teresa said, there were differences from 1991 in terms of access to abdomen, in terms of operation, and 2022. So the world changed, and bariatric metabolic surgery changed. And for this, the leadership of the two societies decided to convene, to produce this joint statement with very important modification and extensions of indication. So this is a step that I consider very important, because also for the evidence of the guideline, when you have an innovative indication, when you have a new indication, it's more difficult to have a robust literature regarding that new indication. I want to point out BMI 30-35 for every kind of comorbidities, and adolescents every age with high grade of obesity, older patient every age considering frailty of the patient, and every kind of BMI and bridge for other surgery. But what we have to say regarding this document, going back to our pyramid of evidence, is a document of experts. It's a document who has, of course, a literature, but there is the big bias, which is that I search the literature that I want to search. I search the literature in favor of what I want to say, and not the literature against what I want to say. This is the big difference. So we have at the basis of these pyramids, and we had to grow up, so to do prismas and systematic review or meta-analysis in order to define if those recommendations are recommendations with a robust literature with them. Of course, there are different methodologies to do them. The best one we know is great, really great too, which evaluate not only the type of a paper, of course we prefer RCT for several reasons, but also the quality of a paper. And in many cases, we, for example, can see that RCT studies in the grade 2 platform could be considered low level of document because of there is dishomogeneity. For example, in RCT studies with age from 17 to 5 to 70, or BMI from 27 to 70 gives a high dishomogeneity, and in the platform grade, that RCT study that we consider the best paper could be low quality. Second phase is to do an evaluation of our guideline, which is done usually by the agree or agree to, where I want to explain the third part of the domain 3, where there is written that there is an explicit link between the recommendation and the supporting evidence. We are checked in our guidelines through the agree to. So we went ahead and produced the evidence, the scientific evidence of our given recommendation that are approved by the two societies, and we hope to publish them as soon as possible in order to methodologically support the IFSO ASMBS 2022 guidelines with two international team of researchers. One team individuate the prismas and the systematic review. So the prismas were 13, like 13 were the items of the previous guidelines, and 12 were the systematic review. Why 12? Because the item 2, class 2 obesity with no comorbidities, produced no studies. So we had no studies for this item. And then we had another problem with item 6, where we had controversial results. So we had to do some DELFI. So this is the first step with 2 researchers for every item, and then a 3rd researcher in case of disagreement. And the second team who was tasked to solve any issues that were not answered by the prismas and the systematic review, with a DELFI survey who involved 49 recognized MBS experts for all over the world. In the DELFI surveys for the two items, we had 9 statements. Of course, as usual, the consensus was reached when the agreement or disagreement rate was equal to greater than 70%. We adopted this table of the level of evidence and recommendation, and these were our results. As you can see, we have the majority of the level of evidence, which are 2A or 2B. In one case, item 2, we had 5, because as I told you before, we had no result. This is the reason of the DELFI. And we had a grade recommendation B. But in majority, the majority of the cases of our items, we had always a good grade of recommendation B, except for adolescents with a grade of recommendation A. This is an example of a prisma with all the systematic review and the recommendation that we gave. So this is the comment that we give in a table in the final part of our paper related to recommendation, and I thank you again to all the authors for the revision. I think this is one of the documents more revised in the world, and I am happy of this, because I'm sure that it is a possibility of mistakes very, 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 very low. Just to introduce the Italian, Italy is strange, because in this case, I don't know why, Italy is very severe, because we have a law, 1217, of our Ministry of Health, who says that if you want to develop a guideline, you can develop only through a grade methodology and with an agreed-to evaluation. So, of course, we evaluated all the items that we performed in the international guidelines, and I have to say that after the individuation of the PICO, which corresponds to the item of the international guidelines, we have approved and recommended with grade methodology all the items except class 2 obesity with no comorbidity. We have a bias with this class of patients, not because there is no indication. In our opinion, there is a big indication for this class of patients. But the problem is that there is no literature. The authors in the past didn't think to do papers, documents, studies regarding this class of patients. So today we have a methodological problem, in my opinion, not clinical problem. And what I want to say that first of all, we upgraded our document. Now it is the effect of a systematic review. It has been processed by a panel, and we can call it guidelines. But we have to consider that there are part of patients today out of the guidelines, out of these items. I told you just before regarding class 2 with no comorbidities, but as in another type of medicine, for example, in oncology, we had in the past radiation therapy, chemotherapy, surgery, and now we have genetics, immunotherapy, target therapy. Considering the complexity of obesity, we should tailor better for some patients some treatment. So the take-home message from my point of view is that the new IFSO-ASMBS 2022 have made history. A methodological upgrade has allowed them to be called guideline. The great method, I love it, of course, but could have some limits, especially for new indication, for new option. There are no defined criteria for the use of a specific treatment for a patient-tailored decision in order to optimize MBS outcomes. I recommend you next year IFSO-EC Congress in a very nice historical cultural city with an innovative program, Venice. See you and thank you for your attention.
Yeah. So the question is now, how are these new guidelines implemented all over the world? And it is my pleasure to share with you the situation in Europe. Can you go back and, yeah, here we go. So worldwide, 34% according to this paper that was published by Juan Pujol, and I was also co-author of that, approximately 1/3 had already adopted the 2022 guidelines at the end of last year. And how is the situation in Europe? And the European chapter consists of 32 national societies. Those 32 national societies contributed to our registry with, at that time, with 172,000 procedures. The problem is that the situation in Europe is not homogeneous like in other countries, but we have a lot of different nations with their own healthcare system, the majority very well established public healthcare system, and I will go with you through those in a few seconds. So what did we do? I sent a questionnaire to all the national presidents of the European chapter, to 32 national presidents. 81% answered it, so 26 out of 32, and we asked them 10 questions. Are the new guidelines implemented? Is there reimbursement? That's in Europe very important, because if you don't have public reimbursement, actually it will not happen for class 1 obesity and diabetes. Is the reimbursement for class 2 obesity without comorbidities, which means according to the new guidelines? Is the reimbursement for BMI 40 without comorbidities according to the old one, and of course also class 2 with the old one? Then have you asked the Obesity Society, the national, for endorsement? Because in my experience, that is extremely important. If you don't have cooperations with the internists, the public healthcare provider in Europe will not listen to you. They won't listen solely to surgical guidelines, but they want also to have some cooperation and endorsement by the internists. And seventh question, has the National Obesity Society endorsed the new guidelines? Were the new guidelines presented to the healthcare insurance and public healthcare providers? And what could IFSO European chapter do to promote this and help you? So the 5 biggest countries in terms of operation, numbers of operations, are in Europe: France, followed by Turkey, Italy, Germany, and Belgium. So how is the situation exemplary in these 5 countries? In France, we have a very special situation. They are doing a great job implementing the new guidelines. You see they are implemented, especially for class 1 obesity and diabetes, and they have reimbursement for that. So really great news. But you also see that for class 2 obesity, which was a problem for the level of evidence supporting this indication, there is no reimbursement. And I don't know a single country in Europe at the moment where class 2 obesity without comorbidity is reimbursed in the public healthcare, by the public healthcare provider. The rest is, you can read it yourself. We had in France active participation of the Obesity Society of the National, and they endorsed the new guidelines, so very important situation. In France is in a certain point special because they have their own health technology assessment agency, and they have a very strict process, and usually they only endorse new procedures when they make their own RCT on that. I give an example. For the one anastomosis gastric bypass, it was the Yomega trial. And it came out with 200 centimeters that they had more nutritional deficiencies. So there was no public, or there is currently no public reimbursement for the OAGB in France. They are looking at that now in a new study. They have now the 5 years results. They are much different. So France, with this health technology assessment agency, has its own rules. And again, all over Europe, no uniform rules. Each country has its own rules, its own national public healthcare system, and in some countries it's even more complicated. Turkey is in Europe a little bit of a black box. We have a lot of medical tourism from all over Europe going to Turkey. Unfortunately, the Turkish metabolic bariatric president did not answer, but I got, of course, information from other sources. The current IFSO president provided, the current EASO president provided some information to me. So the reimbursement in Turkey from the public healthcare system is only in selected cases. They have to undergo a very strict process, so it's kind of really difficult. Italy, again, Maurizio already commented on that. They have national guideline system, so a very unique situation again. They don't stick to what happens in the rest of Europe. If you believe that the European community has anything to say for the national healthcare system of the single countries, you are wrong. There is no uniform situation that covers all over Europe. And you can see again, class 2 obesity is not covered. Class 1 obesity and diabetes is covered if medical therapy fails. So this is the situation we face in Italy, and you can check up, if you're interested, the guidelines on this web page. The National Society was included in all the process. They were part of the board that wrote the guidelines. Germany is again a little bit different. Germany has around 82 million inhabitants. Metabolic bariatric surgery in Germany was severely underserved for the last 20-30 years because each patient had to apply at the public healthcare provider with a very strict process, a lot of hurdles for the patient. Now it's getting slowly better, but you still see that in Germany the new IFSO guidelines are not implemented. Reimbursement for class 1 obesity more theoretically but not practically. Class 2 obesity, again, not reimbursed, and the rest follows what we have seen before. Here you see that the new guidelines from the German Obesity Society ignore the latest IFSO guidelines, so the cooperation with the internists could be improved, let's call it like that. So Germany still struggles a little bit with the new guidelines to implement them. Switzerland, I go now to small countries that maybe did exemplarily a good job. Switzerland did a very good job. They are really precise, as we know from the Swiss. And you see they implemented the guidelines, and they have also reimbursement for class 1 obesity under certain conditions. Certain condition means if they fail conservative treatment and have a certain HbA1c, which is a very rare condition. If I remember right, the HbA1c cutoff that you are allowed to undergo surgery is 8.0. So if conservative treatment fails and you end up with an HbA1c of 8.0, the public healthcare system will reimburse surgery, which is of course not that often the case. Otherwise, they really did a great job and also took the National Obesity Society with them. Then, of course, we have a lot of other countries all over Europe that are small, that are maybe at the border to the eastern part, and I will show you just Georgia exemplarily. Here, public healthcare provider and insurance companies do not cover the cost of metabolic bariatric surgery, and so they do not pay for the new indications. And the same is, for instance, true for Azerbaijan. Again, public healthcare providers and insurance companies do not cost the cover of bariatric surgery. In Austria, the country where I live, the situation is currently let's say, moving. We are negotiating with the public healthcare provider. We do have the endorsement of the National Society of Internists, but it was on the edge. They had a tie when they voted on that, and only because of the president of the National Society was in favor of our new guidelines, we won that race. So it's a very special situation. So to conclude, the implementation of the new guidelines in Europe is very difficult. It happens on a national level. The problem is that in many countries, obesity is still not recognized as a disease. Some countries do not reimburse metabolic bariatric surgery on a public health care provider at all. We do not have a general policy on a European level. And the reason is, as I mentioned, each country has its own healthcare system, and the European community has no influence on that. So what is the to-do list? Of course, to recognize obesity as a disease. You see some countries have done that almost 20 years ago, like Portugal. In the UK, it happened just 1 year ago as a chronic disease. Italy has, again, a special situation because this comes from a lawsuit, and actually this is what they claim. Further to-do list is, of course, I think we have to go for endorsement by the endocrinologists and obesity societies. Only if we do it together, we will be able to convince the policymakers. And of course, we will, in the long-term run, have to develop treatment strategies on a European level. And I can tell you that the internists do a lot of lobbying on the European level for a long time. IASO tried to convince, they are in Brussels, where the head of the European community is situated, and IFSO European chapter also tried to participate in that. And actually, I'm at my end. I'm very grateful to my team from the Medical University of Vienna because they supported me through the last year, and I want to welcome you or invite you to the World Congress next year in Santiago. And as Maurizio, the next Congress president of the European chapter, already mentioned, lovely Venice is also welcoming you for the European chapter Congress next year. Thank you very much. Yeah. Announcement.
Please, Jay, take the podium for the implementation of new guidelines in USA. Just, Gerard, in May 2024, so 3 months ago, the Italian Parliament declared that obesity is an illness, a pathological condition. So for us, it's very good news. Please, James, sorry.
Hi, good morning. My name is Jaime Ponce. I'm the president of the IFSO North America chapter, a surgeon in Chattanooga, Tennessee, United States. And I'm going to tell you what's going on first in the United States and how the implementation of the guidelines have gone through. These are my conflict of interest. Nothing of those will conflict the presentation, and my case makes disclosure. So United States, as you know, if you look at the map, highest rate of obesity in the world among some few countries. In Australia is also there. We have about 42% of the adult population in the United States being suffering from obesity, but it is estimated that the obesity rates have tripled over the last 25 years or so. And it's also estimated that by 2030, about close to half of the Americans are going to be suffering from obesity. So this is a devastating thing that is costing a lot of billions of dollars. And I took this slide, which in the past was posted by CDC, which is a big change in between 1950 and now in the food portions. And just to give you an idea of what's happening in the United States, as well as how the growth of cases in the United States over the years have grown significantly, especially when laparoscopic cases came in. In the United States, we're still doing, over the last 10 years, more commonly, sleeve gastrectomy has replaced, the room-wide gastric bypass and the gastric band. And the latest numbers still show 280,000 cases, but having still the sleeve and the bypass as the most common cases. Now, we expected in 2023, maybe the case volume is going to be down. We still don't have the final numbers, and many causes can be contributing to this. But you know, I have asked in Twitter, this is an informal survey, to my colleagues in the ASMBS if they have struggled with the volume of cases, and I did that at the end of 2023, and amazingly enough, 46% of my colleagues says that the volume has decreased. So this is real. I asked Neil Flock, which is another colleague of mine that has a lot more followers than me on Twitter, and so he did the same survey a few weeks later. He asked me to do it, and 57% of the followers of him, ASMBS members, show some decrease. But let's move on to the insurance aspect, which is interesting. I'm showing you that because in the era of struggling with cases and the new guidelines, you know, we also have the conflicting issue about the GLP-1 medications. But in the United States, we do have about more than 500 health insurance plans. So this is very different than what you saw in Europe and what you see in many other countries. It's not like a national healthcare system. We have to deal with more than 500 different insurances. We have public payers, you know, like Medicare, Medicaid, and military veteran systems, and we have a bunch of private payers. And then we also have a lot of self-funded employers. If when you divided that among the population, you can see there that it's about more than 200 million people that have either private payer or commercial payers or self-funded employers. But then there's another significant number of people that live under public service, public insurance healthcare. Then when you look at overall the coverage of the population, and this is OAC estimations, about 70% of the people have coverage for bariatric surgery, and about 25% of the people in the United States have coverage for obesity medications. So when you look specifically at bariatric surgery, we have about the cases that are being submitted and done in hospitals. About 70 to 80% have commercial payers, about 12 to 15% have Medicare or public payers, and very small percentage pay cash for it. And just to give you the plethora of different insurance so you can understand how we're dealing with, we have many names around that cover our healthcare system: Blue Cross, Aetna, United, Cigna. It's almost like dealing with them. It's almost like going to the exhibit and dealing with all this plethora of names to get coverage just for healthcare. And so the biggest distress that we have in our programs is that we have to deal with their own criteria for bariatric surgery coverage. So these are the main insurance that we have to deal with and how the accreditation has dealt with them. So we have Blue Cross having their own center of distinction, and then United having their own center of excellence, and Cigna and Aetna. In all those centers, they have to work with us, or we have to work with them to see if they can use our criteria so they can adopt our guidelines. Since I was president, we tried to discuss this with the leadership of the insurance companies so we can adapt our accreditation process. And sometimes we make an inroad, sometimes it's difficult to do it. But one thing that the ASMBS has is this very well structured, what I call it military army force, in which we fight insurance not at a national level but at the local level. We have 50 states in the United States, and every state is fighting at a local level because we have very different insurance per state. And even within each state, it's just so many conflicting different insurance locally. So each state has a chapter. Each state has a representative that we call a star and fight the insurance. Then we have at a national level an access to care committee, which is very well populated with members of our society that are very active of fighting and lobbyists in our favor. We also have included all the chapters members, and so you can see that committee is populated with a significant number of members. In addition to that, we have the industry helping us. The industry has a lot of lobbyists that can help us to fight with insurance the coverage. And so when you look at this army of people, you know, we have the ASMBS dealing with insurance, and then we also have at a different state levels dealing with the insurance. So when the new guidelines came in, we had a lot of PR, as you remember. You know, we put that. So even USA Today and many news media outlets create the guidelines. And at the beginning, I was a little bit hesitant. Is this going to make a difference? One of the things that the ASMBS did is just start sending letters to all the national medical directors. And this letter looks like telling them how appreciative we are about their coverage for bariatric surgery, telling them also that the older guidelines have been replaced. They've been there for more than 30 years and now have been replaced with evidence-based new guidelines. And also we expected to them, it's been published in the 2 journals, and we expected for them to implement those new guidelines by a timeline. And it was very clever to put a timeline. We say March 2023, so we can start getting a response from them. This letter was signed by the president at that time, which is Teresa, you already heard her, Scott Shikora, from the IFSO side, and from the Access to Care Committee, John North. But this created a lot of traction. Phone calls from this, following this letter, get a lot of traction. And it is nice. You know, we start getting a lot of insurance start changing the guidelines. You know, just to give you an example, I practice in Tennessee, so you see Blue Cross Blue Shield from Tennessee start letting us do adolescents up to age 13, BMIs of more than 35 without comorbidities, BMIs of 30 to 35 with even severe sleep apnea and diabetes, which is pretty amazing that that happened. Now, this is not a wide coverage. If you ask me today, it's about 95 million lives covered that are having some changes implemented in the guideline. Now, it's not the whole population, but there's some of that. And so in the IFSO survey, you already heard that, you know, United States is one of those that claim that we have adopted the guidelines, but we still have some work to do. I think the biggest work that we have to do is also among primary care physicians. This is a study that was presented in the ASMBS annual meetings, you know, large academic U.S. institution survey among all the primary care residents, advanced practice providers, and faculty. If they were aware of the new guidelines, then 95% were not aware. So we still have a lot of work to do with our medical colleagues. 16% correctly identified weight loss from metabolic bariatric surgery, and 47% correctly answered diabetes remission rate. 72% reported inadequate metabolic surgery education, and 85% were interested in more education. So there's still a lot of opportunities in the United States to continue to do this work. I think we're going to continue our advocacy work. I think that's one of the strengths that we have in the ASMBS. The Access to Care Committee continues to be expanded, more solid, and more stronger. And this is what we do. You know, we just share the information to everybody. This QR code will give you straight to the guidelines. You know, there's many ways that you can start sharing these guidelines to everybody. So in summary, I think a strategic relationship with payers was needed in the United States just because of the way our healthcare system is. I think the ASMBS has organized what I call an army within the Access to Care Committee to fight this issue, you know, state chapters and interacting with all the national medical directors. I think that constant communication and engagement with payers is important for us. And ASMBS's IFSO collaboration was critical to put these guidelines document intended to replace the antiquated 30-year-old guidelines or consensus. But this document has been so easy to read, has been easy to follow, even though we already have other guidelines in the past, was adopted much easier by the payers because that's what is easy for them to read, summarize, and adopt it, and it happened. I am impressed, but it did happen. So thank you very much. I'm also inviting you to the IFSO 2025 Santiago World Congress meeting.
All right, so it is my pleasure to introduce our next speaker, who really needs no introduction, but Dr. Scott Shikora is a past president for IFSO, and we have worked together very closely on many projects, and I will tell you that he also worked tirelessly on the original indications and on getting the evidence paper out. And it really was a lot of work, and he really supported collaboration. We need to work together, and we need to get this over the finish line. And so I want to tell you, he is a big engine behind this great accomplishment. And he's going to be talking to us today about the endorsement of the new guidelines by other scientific societies and what we need to do next. So, Dr. Shikora.
Thank you very much. Good afternoon, everybody. It's a pleasure to be up here. You heard such good talks up to now that I don't have anything new to tell you. It's all been covered. They were so wonderful and so well brought out. I'll fill in a few gaps here and there and tell you a little bit of how this all started. This is a passion of mine forever. I've always said, we're using guidelines from when? Oh, they're 25 years old, they're 28 years old, they're 30 years old. What else in medicine do we have 30-year-old guidelines for how to practice? So anyway, when I became president of IFSO, I wanted to have a project to work on to start the year off, as most of the presidents do. You come in with your pet project, and this was it. And I mentioned it to somebody at a conference, and they said, yeah, the president of ASMBS, Shanu Katari, he wants to do the same thing. So I went to him and said, why don't we work together? If you deliver ASMBS, that's half the population of the world that needs surgery, and IFSO's the other half. This way we have the whole world covered. And we agreed, and this was unprecedented. I don't believe they've ever worked together before. And we put together a writing committee, and as Maurizio told you, we went through the literature, we came up with the 13 points, and then we left it up to him and the statisticians to figure out the statistical significance. Was it there, was it not there? And we nailed it, I think, on 11 or 12. I had thought 11, you said 12 today. Areas where we can demonstrate that there was statistical significant superiority to surgery over medicine for these patients. And that was big, and then using the Delphi, we were able to get consensus on the two that there wasn't enough data in the literature to support it statistically. And that made a pretty good splash with the paper, as you heard. And then we decided that we needed to write the second paper, which was the one that justified the results, that nobody can take the paper and say, well, you used all these little case reports and these junky little studies in the literature, so your final outcome is not valid. So they can't say that now because we had very good papers, a lot of large database analysis as well as RCTs, et cetera. So, and it was a labor of love for me, and I know for many others, because we were doing something that was just not done before. I have no conflicts of interest. I'm not going to go over everything because you've heard it already several times, but the guidelines in 1991, everybody picks on it, but actually at the time, it was revolutionary because there were no guidelines in bariatric surgery. It was a free-for-all. I could decide to sew somebody's butt to their face and call it a bariatric operation, and nobody would have questioned me, as long as, you know, I didn't make a big splash on the complication line. So this was an attempt, this was a pressure put on the NIH to do this because they need to have some control over who was having surgery, what kind of operations. For those of you who've been around the block a bit and are at centers that had a bariatric program for a long time, I can't tell you the wild procedures some of the patients came back needing a revision from. I've never heard of doing something like this or something like that. So there had to be some regulation, and I give them credit for that. And this was the first attempt. Now, between 91 and 98, they had a couple more meetings, but they didn't make any changes to these original 91 criteria. And then they decided that it wasn't for them to be in the business of writing guidelines. That then fell on some of the medical societies, like I believe the Diabetic Association. Now we have internists writing the guidelines for surgery. So it was long overdue. Now, other problems with this. The only operations done were the open gastric bypass and open vertical banded gastroplasty. Totally different than what we do today. No harmonic scalpels, no robots, no laparoscopy, which really changed the world. And they created a panel. They got together people that they considered to be experts for a 2-day meeting that occurred in May of 1991. And these experts were internists, researchers. There was 2 surgeons. One was retired, and it doesn't even say what kind of surgeon the person was, and the other one was a practicing surgeon. So you had 14 panel members with 1 real surgeon on it. There were 20 presentations. Most were given by surgeons, bariatric surgeons at the time. And after each presentation, there was back and forth between the person giving the talk and the panel. And then at the end of all this, the panel got together and they huddled and they wrote up the guidelines. So there's a lot of opinion involved and bias involved with that as well. And the major problem with this, in my opinion, the major problem is it relies heavily on body mass index, BMI. Now, BMI is decent for saying this is a population with that are prone to obesity, et cetera, but for individual people, not so good. And my other talk on this that I had given yesterday, I have a slide where I have Shaquille O'Neal, a basketball player whose BMI is 37, 38, but he doesn't have an ounce of fat on his body. And then a couple of other people, even at the same BMI, you have completely different outcomes. And also for using it as a cutoff for surgery, 35, what's the difference between 34 and 36? Well, BMI 36 goes to the OR, 34 gets rejected. I mean, that's ridiculous, but that's what we've been doing for 30 years. In addition, as you might have heard earlier, people who come from Asia have a different degree of abdominal adiposity versus subcutaneous adiposity, and they're more likely to get the metabolic syndrome at lower BMIs. So you are discriminating terribly against that population by not operating on them when they come to you with metabolic syndrome and their BMI is 33 or 32. So those were the major problems that we had with that. And obviously the world has changed since '91, you know, going from open to laparoscopic to robotic. The sleeve wasn't even a twinkle in anybody's eye at that point. The band had not really gotten going. It was just coming around. So it's a different world, and the guidelines can't fit the current way we do things. So we needed to do new guidelines. And we also, the only field I knew that were using guidelines that were that old. And they were based a lot on opinion. The papers that were used by the 1991 Consensus Conference were papers written in the 70s and 80s. So as you can see, long overdue, and we needed to be evidence-based. And that's how we got going. This is just the same data that you just saw. And we need to also credit Dan for the work he put into this. He wrote a beautiful paper. Maurizio showed you this before. This is the breakdown. And you could see that we have extremely good level evidence with high grades down the line. And the two that he had brought out that we could not get statistical significance was more for a lack of volume of papers and patients than it was anything else. So it's very possible that somewhere down the road, we may be able to pick those two back up. And we published on the same day, which was no easy task to coordinate two publishers with academic papers on the same day. We had some publicity and a splash. There was some interviews given, and it put us on the map, but then that's where it stopped. So what do we need to do now? And I think Jaime raised it, and I think Teresa did as well. We need to get the word out. We need to tell the world we've got a better set of guidelines. It's safe. It's backed up by the literature, by randomized controlled trials, by thousands and tens of thousands of patients, and it's there for the taking. And we need to make sure, because the way it is now, we wrote this beautiful document, we wrote a second beautiful document, and nobody knows that it exists. So we got to put it to work. And, sorry, wrong way. So you heard about the second paper, and I just want to say a word about it. This was the real hard work, because Maurizio had to go back to all of those cases and do a Prisma on it, and then look at all these articles again. And I know he worked very hard on it to get it done. And it has been accepted. The paper actually was written 1.5 years ago, long done, and it's been sort of, it was like a ping pong game between the two publishers to try to get it co-published again, which I think in the future we don't do open access. We just publish. But in any event, that paper should come out any day, because every week I'm told that the typesetter had a problem, there was a flood in the publisher, and every excuse in the book for something that should have come out quite a while. But it still is relevant, and it will come out. We need to create noise. We need to let people know, let the insurance industry know, let the health ministers in countries where there's a health ministers know, let the insurance companies, the private insurance companies know that we're not trying to just expand volume, we're trying to take good care of patients. And if they buy into that, they should understand that it's not going to raise their costs significantly. It's just going to add a little bit more safeguard. So that's the challenge. Now, surveys have demonstrated that primary care docs, their patients, the families of their patients, they really don't understand what bariatric surgery even is. And if they know somebody that had surgery 20 years ago and had a bad outcome, they put their weight back on, that's their memory and their recollection of what bariatric surgery truly is. And we know it isn't. So if we don't get this out, it's not going to amount to much. So I suggest that we look at every potential angle of how to make a splash. Do we need to set up a task force in the organizations to work on this? Maybe we do. But things that we can do now is we can contact our primary care docs that work with us and give them the document and say, you know, here are the new guidelines. See if you can get in the face of the insurance carriers in your area. Use all available weapons. And social media probably is the best one that we have available, and probably has more opportunity than anything else we can do. But I say we do everything that we can do to get this going so that we can then tackle the next issue. So these are just some thoughts that I put down as ways to get the word out. And one big one would be to write letters to the editor of journals, editorials, brief notes, and don't put them into surgical journals. They don't need to go into SORD or to obesity surgery, because we know already that the people who read those know about the guidelines because they're right here. We got to get that into the medical journals. Primary care docs, gynecologists, that's where the potential is, because they're taking care of patients and they're the ones making that decision. They're the gatekeepers. And it just demonstrates. I was very impressed with this, and Jaime brought it out real well. I was going to say, look, 95 million people in covered lives are in programs where they're using our guidelines, and that's really terrific. We should try to get that even higher. And pretty much, thank you very much.